Here on the right are our group data. You see that all three rotator cuff muscles on the left have a larger gain scaling slopes, which are shown on the y-axis, than all 6 primary shoulder movers. So in other words, their reflexes were more sensitive to the background activity than the reflexes in the primary shoulder movers, resulting in overall larger reflex amplitudes across similar conditions. Sorry, the recording thing popped up. So bottom line here, reflex muscles provided more robust feedback responses to unexpected translational perturbations that may cause shoulder dislocation, in part because the reflexes were more sensitive to background activity than primary shoulder movers. And finally, as we step forward, rehabilitation to prevent dislocations following injury and to prevent subsequent dislocations may be able to target feedback stability and can emphasize the larger responses that we saw in rotator cuff muscles. Next.
Perfect timing. And so we'll move on to our next talk, which is by Taylor Trentadue, and assessing biomechanics in a cadaveric model of scapholunate injuries using 4D CT.
Great. Is everyone able to see my screen okay?
Yes.
Great. Thank you very much for that introduction. And I'd like to begin by thanking all of my co-authors for their contributions to this work. The scaphoid and the lunate comprise the proximal carpal row on the radial aspect of the wrist. Scapholunate instability occurs when the scapholunate interval is damaged or disrupted. Scapholunate ligament tears modify the space or the diastasis between the scaphoid and the lunate, and when left untreated, radial translation of the scaphoid may contribute to radiocarpal osteoarthritis development. Standard diagnostic imaging may not allow for optimal scapholunate interosseous ligament injury detection. Traditional radiographs are limited by overlapping anatomy of the carpus. And while 3D imaging modalities such as CT and MRI overcome this limitation, they're generally collected at only one time point. However, dynamic instability may present at certain points within carpal motions, demonstrating the need for dynamic imaging. So today, we're presenting the use of 4-dimensional computed tomography, or 4D CT, to assess changes in interosseous or between bone proximities in a cadaveric model of progressive scapholunate interosseous ligament injury. For this study, again, we used 4-dimensional CT, which is standard 3-dimensional CT scanning, but over motion cycles, thus making the 4th dimension time. For our image acquisition, we used a 2nd-generation dual-source CT scanner, which involves 2 X-ray sources with opposing detectors that are mounted within a CT gantry. This rotates during image acquisition for both the neutral, static, and dynamic CT scans of all specimens. This allows us to achieve high temporal resolution images of the wrist. This is an example of how a participant would be positioned within the CT scanner during their image acquisitions for both neutral and the motion conditions. For our image processing, we first began by segmenting the neutral static CT volumes of the relevant carpal bones. We next worked to register the static bones to the dynamic CT volumes for each time point in each motion. Next, we created bone surface meshes that we used to define coordinate systems of the wrist and also to represent bone contours. And ultimately, we are interested in measuring the distances between adjacent bone surface meshes at each time point between the relevant bone pairs, which for this study were the scaphoid and the lunate and the radius and the scaphoid. And this animation demonstrates the changing proximities between the radius and scaphoid on the scaphoid facet of the radius. We were next able to create animations demonstrating how the wrist was moving during both flexion extension and radial ulnar deviation. For the study presented today, we collected data from 6 cadaveric specimens, and we used a custom motion simulator to move the wrists between flexion and extension, and also between radial and ulnar deviation over 2-second intervals. For today's presentation, we present demonstrative data from 1 cadaver during flexion extension. For the study, data sets were obtained with the wrists first intact, and then under ultrasound, we've conducted progressive ligament sectionings, such as demonstrated by these pictures. Our sequence involved first looking at the wrists in their intact or pre-cut conditions, and then we subsequently sectioned the volar, membranous, and dorsal scapholunate interosseous ligaments, followed by the radioscaphocapitate ligament and the long radial lunate ligament. These proximity maps are demonstrating the changing distances between the scaphoid and the radius on the scaphoid facet of the radius. We've included two cuts here, the first being the intact condition and this one being after injury to the dorsal scapholunate interosseous ligament. Yellow is representing closer proximity and blue greater proximity or more distance. So we were able to then quantify the interosseous distances by looking at the distance distributions between the relevant bone pairs at each point in the motion cycle. The white dots on these violin plots are representing the median distance between the bone pairs at a given time point in the motion cycle. From this, we were able to create distributions representing the median distances at each bone pair interval during each motion. From this, we found that there are no statistically significant differences in interosseous proximities between the first three ligament conditions and the second three ligament conditions, but there were statistically significant pairwise differences in these median distance distributions between each of the first three ligaments and each of the last three ligaments at scapholunate interval. We saw a similar pattern at the radioscaphoid joint, with the exception of the relationship between the volar and dorsal scapholunate interosseous ligaments. So this study tells us that 4D CT-derived proximity maps can quantify the relationships between ligament severity and changes in interosseous distances at both the radioscaphoid joint and scapholunate interval. And we hope that patterns derived from these data may help the diagnosis of in vivo scapholunate injury and ultimately surgical planning and postoperative evaluation. Thank you.
Thank you, Taylor. Excellent talk. Our next presentation will be by Amy Morton, dorsal subluxation as a prognostic metric of progressive thumb carpometacarpal osteoarthritis. Go ahead and share your screen, Amy.
There we go. Can you see and hear me?
Yes.
Okay, getting some nods. So thank you for the introduction. As Anita said, we're going to discuss dorsal subluxation as a prognostic metric of progressive thumb carpometacarpal osteoarthritis. And pivotal to our discussion is a question: can we use biomechanics to predict disease progression? To this end, we're going to be analyzing, or we're using data from 90 OA individuals from an NIH-studied longitudinal study on thumb CMC-OA and the biomechanics associated with OA progression. Individuals were recruited at baseline with clinical and radiographic signs of osteoarthritis, and as well recruited with age-matched controls without any disease radiographically or clinically. And those individuals were followed up over a 6-year study period. At each follow-up, we acquired patient-rated outcome measures, x-rays, but specifically to this talk today, we'll be discussing the CT scans acquired at each data point. We had individuals in a braced neutral position, as well as 11 different poses of thumb daily range of motion activities. From those CT scans, the hand bones of the hand and wrist were segmented. Using the segmented surface models of the metacarpal and the trapezium, we were also able to robustly quantify the articular coordinate systems for both the metacarpal and the trapezium. Using the coordinate systems for the MC1 and the trapezium, we are able to talk about the metacarpal position relative to the trapezium. As you can see in our bottom plot, our small gray dots indicate the metacarpal origin on the trapezium surface. Specifically, can quantify these as a percentage corrected for bone size, and where 0 being a stacked coordinate position of the metacarpal and trapezium, and the moving away from the extents of that origin, both in a direction, specifically dorsal, we would come to the edge of the articular surface, and that would be a 50% offset as depicted by this. So when we're talking about disease progression, we noticed in our data set that individuals did not all progress at the same rate. We can see that the bone models of one specific subject, over time, there are gross bone remodeling. In a very similarly aged individual with early signs of osteoarthritis at baseline, followed over the same period of time, this individual did not showcase the same or very little bony remodeling. This was indicative of many different subjects in our cohort. So we thought to subdivide our osteoarthritic group into two different categories, advancing and stable osteoarthritis. To do so, we used osteophyte volumes computed from the bone models, and we thresholded individuals based on their osteophyte volume and rate of growth. This gave us an advancing and a stable osteoarthritis subgroup from which we could compare to the control cohort and within subgroups, specifically trying to determine what characteristics of MC1 position differentiated stable osteoarthritic patients from those who exhibited more rapidly advancing disease. When we examine the MC1 positions across all 11 poses acquired in CT scans, annotated on the x-axis, we readily observe, one, that the MC1 position on the trapezium differs by thumb pose. The magnitude of my MC1 position offset on the trapezium is different for each one of my poses. We also see that the offset is increasing with disease. My yellow to increasingly red plots are my advancing category, and my teal and light blue are the stable. My control individuals at both 0 and follow-up time point 6 are annotated in black and black dashed lines, respectively. This also shows us that there are positions where a magnitude of offset on the metacarpal does not necessarily, of the metacarpal and trapezium, does not necessarily mean subluxation. Nominal values of controls and stable individuals had high magnitudes of offset, as did our individuals with advancing OA. But in other positions, the difference between stable or control and individuals with osteoarthritis or advancing osteoarthritis was much greater. The differential of the metacarpal offset in control or healthy to those with disease is an indication of subluxation, and that subluxation was increased with disease and time. So our statistical aim was to identify poses or combination of poses that had the greatest differential ability or prognostic ability to see who, or detect patients who would be stable versus advancing. Poses that gave us the greatest classification power based off of their C statistic were poses of flexion. Specifically, we analyzed the data across our poses at both a baseline value and a rate of change. On my left, I'm showcasing my subgroups, advancing in red and stable OA in blue, as well as my controls for reference. I've also depicted...
5 minutes, sorry to interrupt.
Oh my gosh, really? Wow, that went fast. I am 2 slides away.
Sure, just go ahead and finish.
Yes, just to wrap up, we were able to, with high sensitivity, to produce cutoff values using rate of change for the metacarpal position on the trapezium and subluxation in flexion and pinch. The significance of using this outside of a CT scan is still yet to be remained. So the question of can we use the dorsal subluxation in a clinical screening test remains unknown. Presents a lot of interesting questions for this. Sorry for going over time. Thank you.
Thanks, Amy. And our final talk in this first group is by Stacy Loushin from Mayo Clinic, and it's human exposure to hand-arm vibration from a surgical drill during spine surgery. Go ahead, Stacy. Stacy, I think you're in the presenter view.
Can you see it now?
There, great.
Perfect. All right, thank you for the introduction, and I would like to thank the program committee for allowing me to present to you. Today, I would like to discuss the human exposure to hand-arm vibration from a surgical drill during spine surgery. Hand-arm vibration has been characterized in occupations involving frequent exposure to vibrations using handheld equipment. Increased exposure to vibration can result in neurological, vascular, and musculoskeletal impairments, including carpal tunnel syndrome. To reduce these risks, occupational health standards have been implemented to limit exposure. The exposure action value and exposure limit value require employers to monitor vibration and ultimately stop tool usage. Surgeons are exposed to vibrations from surgical drills, and the prevalence of carpal tunnel syndrome is increased in this population. However, vibration exposure has not been well characterized. We look to quantify human exposure to hand-arm vibration from a surgical drill during a common spine procedure and determine if this exposure exceeds occupational health standard limits. We looked at 5 neurosurgery residents who performed 3 30-second lumbar hemilaminectomies on fresh frozen cadaver torso using a standard surgical drill. Vibration measurements were acquired using a triaxial accelerometer rigidly affixed to the surgical drill in accordance with ISO standard 5349-2. The accelerometer did not interfere with the surgeon's grip. The RMS frequency weighted acceleration values were calculated in accordance with ISO standard 5349-1. The daily vibration exposure for the 3 trials in terms of an 8-hour energy equivalent frequency weighted vibration total value represented as A8 was calculated. Based on the A8 values, the EAV and ELV values were determined. We have summarized the values of the 5 subjects, reporting the EAV and ELV values. The time to reach these values was consistent with 4 of the 5 subjects, with the shortest times being 5.4 minutes to limit exposure and 21.8 minutes to stop usage. Subject 2 had the highest values with times of 13 and 52 minutes, suggesting a differing technique. The EAV and ELV values are established by the Control of Vibration at Work regulation, which is a European standard. They represent the maximum amount of time a surgeon should be exposed at the measured vibration level. This includes the combined exposure throughout the day, with the EAV value being as low as 5 minutes and equipment termination being reached in 21 minutes. A surgeon may reach the EAV limit within a single surgery. Because of this, drill usage times become critical. Further investigation is needed to determine the total vibration exposure over a day, specifically in a surgeon who performs multiple surgeries within a single workday. While elimination of tools is not possible, grip technique and vibration dampening materials should be explored. In conclusion, a common surgical drill transmits hand-arm vibration levels approaching EAV and ELV limits over short periods of use. Thank you.
Thank you, Stacy, and wonderful talks by all 4 of you. So we will open this up now for questions. We can take up to 10 minutes, but we also will have extra time at the end. So, and perhaps we might want to start with questions for Costa first because he is running out to another session. So please enter your questions in the chat or raise your hand.
I have a question for Costa, and
Absolutely.
seeing the picture of the baseball player raised the thought, what effect does speed of translation have on the reflexes?
It's a good question. And right now, ours are about, I believe about 5 meters per second. So in very small translation. So we're talking 5 to 10 millimeters, and obviously we didn't want to dislocate anyone. It's a bad look. We only did one there. In our previous studies, that looked at rotational reflexes, there are small differences on the rate of rotation. We haven't looked at that yet from a translation end, except in some of the pilot data. The answer was not much in the range that we did. Our goal right now was to see if they exist, because that was our primary goal. But it is something we're going to try and quantify moving forward, is how much that does change. But we don't expect it to be too much, except if you're so fast that you're going to saturate out that spindle, and so slow that you're not going to activate. So there is a relative sweet spot there, but within the range where we're actually seeing reflexes, we don't expect to necessarily see a big difference in their amplitude.
Okay. Thank you.
No one has another question. I also had another question for Costa too. You've been focused on the stretch reflex, but do you think there might be a role in cutaneous or other kind of receptors in this response?
So the biggest place that we might expect to see those is potentially in the shoulder capsule. And there's been a lot of cadaveric work out of the late 80s, early 90s, looked at some of the cutaneous receptors and actually stimulated those receptors and looked at some of the reflexes that exist in the rotator cuff muscles specifically. And it just takes someone sitting in the experiment and having us translate their shoulder to feel the stretch that you have on the shoulder capsule and those glenohumeral ligaments. So yeah, it's absolutely possible that that there is some sort of capacity to have those signals coming around to the reflexes and potentially offering protection in a very functionally relevant way as you're translating and stretching. You have that feedback. We do, what's interesting is that we didn't get there yet because of COVID and shutdown stuff, but our goal is to look at this in shoulder instability patients, and especially ones that have laxer shoulders, and see how those reflexes change. They might be higher because they have this precompensation, but they might also be lower if there is less background tension on that capsule because it is looser, and maybe doesn't activate some of those cutaneous receptors as much as it would in a healthy, tight shoulder.
Thanks. Any other questions?
I have one for Stacy on the vibrations. I was trying to dive into some of the equation stuff. I guess two questions. One, how much variability do you see in the vibration characteristics of different drills that surgeons are using either for this type of procedure or for different types of procedures? And how much effect does the frequency of the vibration that you have in a specific drill affect that cumulative exposure that you're seeing, or that quotient of cumulative exposure?
Yeah, so I'll answer your second question first. So the frequency is a weighted frequency, and that's all laid out in the first ISO standard. As far as looking at different drills, this was the first drill that we have looked at. And that brings to the last point, is that surgeons are exposed to different drills throughout the workday, and that understanding the vibration that they're exposed to based on the different types of drills and frequencies of those drills could really either raise or lower those limitations or their times.
I can follow up with a question. Again, if there are other questions, feel free to throw them in the chat or also raise your hand too. I had a question for Amy. Amy, I know you were talking about kind of looking at how these biomechanics can predict or help us to assess our disease progression in osteoarthritis. And I was curious kind of how like radiological signs or bony signs of disease progression correlated with symptomatic or functional signs of disease progression. I'm less familiar in the thumb, but I know in other areas those don't always align. And so I was curious in your sample if you'd seen if maybe one is easier to predict than another, or if that differed in the people that you looked at. And you're muted.
Thank you.
Yes.
It's a really good point. There have been some comprehensive systemic reviews on hand OA, basal thumb OA, that show very similar signs, that our clinical symptomology and radiographic presence of OA are difficult to correlate. Subjective measures, a patient reported outcome is not necessarily a sensitive enough test, and there's a lot of other confounding factors. So we find the same disturbance and lack of correlation in hand OA. And I think that's why we were very motivated to come up with a quantitative metric of disease progression and stratification. The use of osteophyte volume as an objective metric to classify our individuals doesn't correlate with their pain, but we had to have something to stand on to go with for our analysis. So if the pain people can come up with ways to objectively measure pain, I'm all ears.
Lots of things to still look at for sure. And then maybe if we have time for one more, Anita, there's a question for Taylor.
Let's do the one
Okay.
in the chat, and then we'll move on.
So Taylor, this is a question from Michael Anthony Gonzalez. He says, very interesting work. I've never seen a cadaver arm in a vise like that. Do you think your work is easily generalizable to other joints, or do you think that the size or complexity of other joints work make the 4D dynamic imaging more difficult?
Thanks so much for the great question, Michael. So as far as if we think this is easily generalizable to other joints, one of the major limitations with the 4D CT technique is the size of the imaging detector. So we're only able to acquire a fairly small volume of any part of the body. So it's a great modality for looking at the wrist, and given its complexity, we're able to get really great temporal and spatial resolution there. So our lab is working on using this technique for other joints in the wrist, or moving in that direction. As far as moving it to other joints, if they're small enough to fit within that volume, I think it could be interesting, but not sure how immediately generalizable it would be.
Gotcha. Cool. Thank you.
Great, thanks.
I think we lost Anita. No. Do you see her, Emma?
No, I was just taking a quick look. She maybe just had to maybe reload or something. It looked like she got a little frozen there for a second. So we could probably move on to our fifth presenter. Does that sound good? So, and in the meantime, I'm sure Anita will hopefully be able to come back on. Marc, I think that's you, unless I'm someone else can correct my list.
I do believe you are correct.
All right. Does that sound good, Trey, if we just
Yes.
move on? All right.
So Marc's going to present on shoulder internal rotation deficit and total rotational motion deficit of the throwing arm are not related to injuries and surgeries in collegiate baseball players.
And just a quick reminder, feel free to put those questions in the chat either as they're talking or afterwards. We'll do the same layout again where we'll have a break with a chance for questions for all the presenters.
Thanks, Amy, for taking over while my internet went away. Or Emma.
Okay. Thank you for the introduction. And yeah, so I'd like to thank the ASB for allowing me to present. So as during the introduction today, I'd like to discuss how these two deficits are not related to injuries and surgeries in collegiate baseball pitchers. So to give some background, shoulder injuries are incredibly common in overhead throwing athletes such as baseball pitchers. A recent study tracked injuries from Major League Baseball players between 2011 and 2016. And during that time, 511 injuries were recorded to the shoulder, making it the most susceptible joint to injury. And of those 511 players who were injured, 395 of them, or 77%, were pitchers, making them most likely to have shoulder injuries. Additionally, these players spent an average of 69 days on the disabled list. So there's a desire in the community to figure out what are some factors that make these players high risk and how can we mitigate them. So some recent, or not really recent, over the past 20 years or so, some factors have been GERD, or glenohumeral internal rotation deficit, which is basically when the shoulder loses at least 20 degrees of internal rotation compared to the contralateral arm. Additionally, total rotational motion deficit, which is when the total rotational motion, which is internal plus external, loses at least 5 degrees compared to the contralateral arm. So these two deficits are kind of what we wanted to look at. Ideally, we wanted to figure out, do these deficits impact the rate of injury or surgery occurrence in collegiate baseball pitchers? So we assumed the null hypothesis that neither deficit was related. So in order to do this, we recruited 177 collegiate baseball pitchers. So typically these shoulder rotational properties are measured by a team physician or team trainer or clinical physician, and they'll have the players lay supine with their arm at 90 degrees of abduction, and then they'll manually rotate the arm internally and externally and then measure what they feel to be the maximum range of motion. Where our study differed is that we actually used a custom sensor that would allow us to measure those angles, and we used a quantitative method to do that, where we said at 40 newtons, that was the endpoint angle. Additionally, we asked players to fill out an injury questionnaire, which identified if they had an injury or surgery in the past year, and then we followed these players for a year to see if they were injured or had a surgery in the 1 year span. For statistics, we used one-way ANOVA to determine differences between the groups, and we used chi-square test to determine significance between groups and the occurrence of injury and surgery. So our results, so this table here shows our 4 exclusive groups, so either both deficits, total rotational motion deficit only, GERD only, or when they had the internal rotation deficit, and neither deficit. So the healthy row were players who didn't have an injury initially or at the 1 year follow-up. SI after were players who had surgery or injury at the 1 year follow-up, and the SI before row were players who had surgery or injury at the initial questionnaire. So we excluded 68 pitchers for this chi-square analysis because we only had the initial, we didn't have the 1 year follow-up, but our results showed that there was no significant relationship between the deficit groups or the categorical groups. This table here shows our bilateral differences plus or minus the standard deviation for each deficit. So here you have total rotational motion. So this is throwing arm minus, or the difference between the throwing arm and non-throwing arm for total rotational motion, and for the internal rotation. We had excluded an additional 8 pitchers for this group because they fell into multiple categorical groups. And once again, there was no statistically significant relationship between the deficits and whether or not they were healthy or had a surgery or injury. So how do these results kind of compare to what's currently found? So like I said, these two deficits are prolific in literature. A study from Kevin Wilk and the ASMI group, who originally proposed TRM deficit, found the pitchers with GERD were more likely to be injured than those without GERD, but not by a statistically significant amount. So similarly here, we did not have a statistically significant relationship between GERD and the occurrence of injury and surgery. However, they found that if they had a total rotational motion deficit, they were more likely to be injured than those without the deficit. That's where our study differs, in that we had no relationship at all between TRM deficit and the occurrence of injury and surgery. So our studies are slightly different. We looked at collegiate pitchers, whereas they looked at professional pitchers. So that could be one aspect. Additionally, we had that custom sensor, which measured the angles at 40 newtons, whereas they used the currently accepted method of a physician feeling for what is that endpoint angle. So sum it all up, GERD and TRM, their role are still not entirely clear. Our study shows that there is no relationship between these two deficits and an increased risk of shoulder injury or surgery, but that doesn't mean that they don't play a role. Ideally, we like to figure out what some of additional factors are that actually make these players high risk so that we can come up with ways to mitigate the rate of injury and surgery in baseball pitchers. And that's what we're going to kind of focus on in the future. So I'd like to just thank all the graduate students from the UNCC Biomechanics and Motion Analysis Lab for their help collecting this data. I'd additionally like to acknowledge Major League Baseball and the National Science Foundation for their funding, some references, and some contact information for later on. Thank you.
Thank you, Mark. We'll go on to the next talk, which is Michael Gonzalez, quantifying peripheral nerve interface and residual muscle control during phantom hand movement.
All right, thank you very much. Everything look good?
Yes.
All right. For individuals with acquired amputation, the continuous control of advanced prosthetic hands is thought to require a well-defined model of the phantom hand and the ability to control it precisely. These control schemes typically consist of several signals from some combination of muscles and nerves in the residual limb, and we can then use a variety of tools such as pattern recognition to interpret these signals and turn them into prosthetic commands. But these methods don't really tell us much about the phantom hand itself. And as such, there's no established method for measuring how much an individual can control different functional movements of that phantom, which may be important in understanding how to go from phantom hand movements to intuitive prosthetic control. Now, one approach to quantifying force and movement control in human motor tasks is through Fitts law, which models the relationship between task difficulty and completion time. In a force matching task, participants might be provided a target like this, which has a specified amplitude and width. And then they'd be asked to hit the target using a real-time visualization of their force output. The task difficulty is then a function of both the target amplitude and target width. So if you increase the amplitude, that's a higher difficulty. And if you increase the target, that decreases the difficulty. Now, throughput is a measure of motor performance, and it's proportional to that difficulty and inversely proportional to how fast the individual can achieve the target. So faster times at the same difficulty equate to higher performance. And this paradigm has been used to measure control in surface and intramuscular control signals, but these were performed on healthy individuals, so we don't get information about that phantom hand. Now, for this case study, we worked with a single participant who underwent a transradial amputation 4 years ago and had indwelling wires implanted 3 years ago. Wires were implanted in 5 residual muscles and 3 regenerative peripheral nerve interfaces, or RPNIs. And these RPNIs consist of a free muscle graft wrapped around a free nerve end in the residual limb and act as amplifiers for the nerve signal. For our experiment, we were interested in studying different signals that corresponded to the same functional movements of the phantom hand, and we decided to observe the participant's ability to control signals from the flexor pollicis longus and an RPNI created for the median nerve, which both showed high activation when the participant flexed their phantom thumb. During the course of our experiment, the participant was asked only to focus on this phantom thumb flexion. We first collected a maximum voluntary excitation for both the FPL and the median RPNI channels by asking the participant to flex their phantom thumb as hard as possible and taking the highest value of the filtered, rectified, enveloped, and integrated muscle activity. The MVE was then used for normalizing target amplitudes and widths. We then conducted a Fitts law task consisting of a combination of 2 target amplitudes, 25 and 50% MVE, as well as 4 target widths of 5, 10, 20, and 40% MVE, which gives us a big variety of difficulties. And these target width combinations were block randomized, and the participant completed 4 blocks for each signal. So onto our results. Here we have the target amplitudes for the 25 and 50% MVE and the average target width across all trials. We grabbed our peak signal amplitudes for each trial with the FPL in blue and the median RPNI in red. And here we can see the average target value and effective target width achieved for our participant across both signals and targets, where this effective target width is essentially a window size adjusted based on the variance of those peak amplitudes. Together, we can see that both signals overshot the 25% by a similar amount and with similar variance. But when going for the 50%, the median RPNI signal was both more accurate and less variable than the flexor pollicis longus. and actually took on average half the time to reach those peak amplitudes. This isn't necessarily surprising, as RPNIs consist of fewer motor units than a muscle, which may mean quicker response times and less latency between user intent and signal amplitude. But all these factors together result in the RPNI having nearly double the throughput, which again is our measure of motor performance, compared to the FPL. So in this study, we were able to quantify the level of signal control associated with the residual flexor flexus longus and the median RPNI as our participants flexed their phantom thumb. And we found that RPNIs had a higher throughput than FPL, likely due to their smaller size. However, we really want to extend this and get more context for these results by extending our methodology to more signals and to more participants, so that we can get a better understanding of how user intent translates to electromyographical action. I'd like to thank our funding source, our amazing research team, and of course, our participant, without whom this would not be possible. And thank you all for listening.
Thank you, Michael. Our next talk will be from the same group by Christina Lee, and it's movement control of upper limb prosthesis users during goal-directed reaching.
Awesome. Everything look good?
Great.
Awesome. Well, thank you for that introduction. I'll go ahead and start. There are many different ways that healthy individuals are able to complete a goal-directed movement because there are more degrees of freedom than what is necessary to complete the task. And this redundant degrees of freedom leads to movement flexibility when individuals are selecting their motor solution. Individuals with amputation with a prosthesis have to substitute their missing anatomical limb, which often has limited movements of the terminal device. It is unclear how using a prosthesis impacts movement flexibility and the ability to utilize the redundant degrees of freedom that exist in human movements. So in our study, we evaluated movement strategy, variability, and dynamic control of both prosthetic and anatomical movements during a series of repetitive goal-directed reaching with different goal frequencies, with a purpose of better characterizing prosthetic movement control. We asked 9 unilateral transradial prosthesis users and their age and sex matched healthy individuals without an amputation to complete a temporal reaching task such that they were changing their direction of their reach with the frequency of the metronome that was playing in the background. We quantified timing error as the time distance between each metronome signal and its nearest point of peak excursion. And as long as they were alternating their direction of their reach with the metronome signal in the background, the endpoint of the reach could be anywhere on the gray shaded region. And as you can see here, this allowed our participants to vary their employed distance and speed without compromising their performance, as long as their distance and speed combinations resulted in the goal movement time. Since there are many different movement strategies that can achieve the goal of the task, we use the goal equivalent manifold, or the GEM approach, that decomposes movement variability to those that are goal relevant and those that are not. And this allowed us to determine whether prosthesis users are able to vary their movement strategy in a way that preserves their performance the same way that healthy individuals can. And in this example on the right, all points that lie along the goal time is a possible and a correct solution to this task. For every reach, the employed distance and speed combination is some tangential deviation along the goal and some perpendicular deviation away from the goal. Tangential deviation is goal irrelevant as it does not impact performance, but perpendicular deviation is goal relevant since it does impact performance. Detrended fluctuation analysis, or DFA, that examines how fast corrections are made in a time series, was used to quantify the level of dynamic control that exists in our outcome measures between each reach. DFA yields a scaling coefficient called alpha, where a smaller alpha value denotes statistical anti-persistence. And in the context of this study, a time series with a smaller alpha value can be interpreted as having faster corrections between each reach, or a dynamic control that requires more effort. In comparing our goal relevant and irrelevant GEM deviations, all individuals, regardless of whether they had an amputation or not, completed the task so that their goal relevant deviations were much smaller in their magnitude than their goal irrelevant deviations. And while we actually didn't see any difference between the limb type in the mean magnitude of the goal relevant deviation, we saw that prosthetic movements exhibited greater variability, which we quantified as standard deviation for the goal relevant deviation. We did not see any significant limb effect, again, in our mean magnitude of any of our outcome measures, but we saw that prosthetic movements exhibited significantly smaller alpha values in several of our measures, such as employed speed and tangential deviation. And this suggests that prosthetic movements were more tightly controlled between reach, which can be interpreted as a greater effort associated with completing this task with a prosthesis than when using an anatomical limb to output a similar level of performance. This may have potential implications on how long individuals can use their prosthesis for and how fatigued they feel after using their prosthesis. In conclusion, our study demonstrated that prosthesis users are able to perform similarly as those without an amputation during a temporal goal-directed reaching task, but they did so with greater variability of goal-relevant deviation compared to individuals who are using an anatomical limb. We also saw prosthetic movements with increased level of dynamic control, which may potentially be more effortful and have further implications on fatigue. I'd like to thank our funding source and our participants and of course our research team. And thank you for listening.
Sorry, it's muted. We have one more in this session, which is Taya Carrillo. I hope I pronounced your name correctly, Taya.
Yes.
Assessing stretch reflexes following post-mastectomy breast reconstruction.
Can you hear me?
Yes.
Okay, perfect. Thank you so much for that introduction. So post-mastectomy breast reconstruction procedures that involve disinsertion of the pectoralis major and or latissimus dorsi have been associated with the reduced stiffness of the shoulder and of the pectoralis major clavicular region. However, the current mechanisms behind these reductions are unknown, but may be related to the altered muscle stretch reflexes, which have been found to regulate muscle stiffness. So Costa kind of went over some of these mechanisms, but very briefly, short latency muscle stretch reflexes involve a spinal mechanism and are of spinal origin purely and involve mechanoreceptors like muscle spindle afferents and motor neurons within the spinal cord, while the long latency muscle stretch reflexes involve more supraspinal structures like the brainstem and the sensory motor cortex. So the aim of this work was to quantify muscle stretch reflexes following 3 commonly performed post-mastectomy breast reconstruction procedures and compare this data to the healthy age-matched controls. Our hypothesis was that the muscle stretch reflexes would be inhibited in patients who had their muscles disinserted compared to those that did not. So we had 3 patient groups. We had subpectoral implant group, lats flap group, and the deep flap group. In the deep flap group, the muscles were not disinserted, but in the subpectoral and latissimus dorsi flap, they were, as depicted in these pictures. We also had healthy age-matched controls. Participants were comfortably seated in the chair with their upper extremity constrained in a cast, and a robot delivered small stochastic perturbations in vertical ABA deduction or horizontal flexion extension, while participants exerted minimal torques in one of the 4 directions. We collected EMG from the clavicular and the sternocostal region of the pectoralis major. Following this, we quantified the short and the long latency stretch reflexes when the muscle was stretched or lengthened. So just to orient you to this slide and this graph, I'm showing on the y-axis change in reflex activity within each of the reflex windows. And the healthy control is denoted in the red, and the rest of the breast reconstruction groups are denoted in different colors. So this is for the pectoralis major clavicular region. We found inhibited short latency stretch reflex and inhibited long latency stretch reflex following all 3 breast reconstruction procedures compared to the healthy age-matched control. Now keep in mind that the short latency stretch reflex is mostly spinal, and the long latency reflex is spinal, subcortical, and cortical in terms of origin. I will come back to that in my discussion. In terms of the sternocostal region, we only found that the short latency stretch reflex is inhibited in the lats flap group compared to the healthy age-matched control. So this is the first evidence of breast cancer survivors that are unable to regulate muscle stretch reflexes as effectively as healthy individuals during postural perturbations. Because we saw this in our DEEP group, which did not have any disinsertion of the pectoralis major or latissimus dorsi, we are now hypothesizing that some of these alterations may be related to the treatments that these patients received prior to breast reconstruction. These involve mastectomy, chemotherapy, or radiation. Radiation has been shown to inhibit muscle stretch reflexes previously, and more recent evidence has come out that some chemotherapy drugs tend to cause aberrant activity of the motor neurons, as well as damage the sensory neurons that are innervating the muscle spindle afferents. Now, considering that the peripheral damage that is sustained by the pectoralis major, and plasticity of our nervous system, some of this damage can be translated perhaps to the more subcortical and cortical areas. So our future studies will try to look at each one of these treatments and their effects on muscle stretch reflexes so that we can delineate the exact mechanisms that we're seeing in these current findings. Thank you so much.
Thank you, Taya. So now we'll open up these past 4 talks for questions. So again, feel free to enter your questions in the chat or raise your hand.
So Michael Anthony Gonzalez has a question for Marc, and the question regards to the 40 newtons that was applied. Was that load based upon clinical significance, or was it a point provided for consistent endpoint?
Thanks. Absolutely great question. So our goal was really to collect quantitative data. So as I try to explain was that the surgeons usually they'll have the players on their back with their hand on the shoulder, and they'll rotate until they feel a bony movement or until they feel like that's about the endpoint angle. And so our sensor, we validated to within 1.5 degrees for orientation and 1 Newton for force. And so our goal was really to get that repeatable quantitative data that's consistent so that way not only a trained medical professional can collect the data, however, it is also clinically relevant. So our results matched up as far as the total endpoint angles very well with what's already found in literature. It's just this way we can bring one more aspect to it where it's not just this is what the surgeon said was their max range of motion. Now we can say, okay, across the spectrum at 40 newtons, where are these players at? And so that way we can kind of have a little bit more information when we're looking at these players.
Totally.
Hopefully that answer your question.
Yeah, thank you.
And then maybe as others are thinking of other questions, I can follow up with a question for Michael. So I thought your talk was really interesting, and this is outside of my field, but a little bit of a hypothetical, or maybe, I don't think you looked at this, but maybe you may have thought about it with your work. Do you think that maybe different control signals or different control sources could be either better or easier to use for different levels of tasks? I know you looked at sort of that 25 and 50% with different width levels, but I was curious if like for very, very small or very high, I sort of imagine there's like a sweet spot that's a bit easier where both could be more difficult, but curious your thoughts.
So I think that that's a really great question. And I think how I like to think of it and where I'd like to take the research next is, when someone is actuating a prosthesis, they're not thinking I need to hit 25% or 50% MVC. And so there are some implicit targets that I'm interested in exploring with people where we're saying, hey, grip as hard as you might grip an apple or a full can of beans or whatever it is, and give some different levels for how much they might use their anatomical limb in order to actuate and grab these different things. So that one, they have an internal model already for what it takes to interact with those objects, but also we know that they're in sort of reasonable ranges for muscle activation anyways. So I think it's something that I'm interested in getting into next, and I think maybe addresses some of that you're getting at.
Yeah, I think that's fantastic and really interesting. It's also fascinating because I think it could vary on how accurate you need to be, right? If I'm gripping a can of beans, maybe it's okay if I overshoot, but if I'm going to grip your hand or an apple, I want to be a little bit more accurate with that. So I think that's a really clever way of kind of getting those targets right. Very cool.
Thank you.
Anybody else from the audience? I did have a question for Taya. I was wondering if you happen to also notice any differences in the onset times of the reflexes in addition to the amplitude.
I actually have not looked at the onset times, so I wouldn't have an answer for that, but that's a really good point. I should go back and take a look.
All right, well, if there are no other questions, we will move on to the next set of, when we only have 3 in this session, in this group, so we should be able to stay right on time. So I have coupling patterns of the cervical spine, alterations associated with neck pain, and Erin Ellingson will be giving that presentation. Oh. Sorry, Erin, did I messed up your order here, didn't I? I had a slip. Since you're from the same group, you're okay, right?
Sorry, I'm muted. All right, well, thank you for the opportunity to present our research. Unfortunately, my PhD student, Craig Cage, is unable to present, so I'll be presenting on his behalf, and you'll see that another one of my students will be presenting after me. I'd also like to acknowledge the other trainees that assisted with the data collection. So as many people are probably well aware, neck pain is a very prevalent problem in our society. In fact, it ranks 4th in overall years lived with disability. So kind of giving an insight into the chronicity that we see in this disorder. We do know that the cervical spine has a large range of motion, and particularly in the subaxial cervical spine, we see a unique coupling where ipsilateral bending or ipsilateral lateral bending is associated with ipsilateral axial rotation. So you can see on this image here, this is an individual performing right lateral bending and associated right axial rotation. However, assessing these coupling nature in the clinic is often difficult. And I should mention that the student that intended to present is a physical therapist. So I'm just using some of his words here. We're often limited to static end range of motion measurements, using a simple goniometer. So because of these, it's not really well understood the changes that are associated with chronic mechanical neck pain. So therefore, the objective of this study was to observe head to torso kinematics and coupling patterns of the cervical spine during both lateral bending and axial rotation tasks in individuals with and without mechanical neck pain. To do this, we enrolled 11 individuals. 7 of them had chronic mechanical non-specific neck pain with a mild to moderate amount of disability and pain, and 4 matched controls. We had each of them perform lateral bending and axial rotation while markers were placed on the head and torso, and we recorded global kinematics. We had each of them do 3 trials of lateral bending where they went from a left position to a right back to a left position, and similarly for axial rotation that was performed under the beat of a metronome. We then quantified the total in-plane range of motion as well as this coupling ratio, which we defined as the percentage of coupled motion relative to the amount of primary motion. So this example is just a trace plot of an individual doing axial rotation, starting out looking left, looking right, where we found the minimum amount of rotation, and then essentially divided that number, or divided the amount of coupled rotation that we saw at that instant in time with the primary amount of motion. We then averaged the coupling ratio and range of motion across 3 trials for each lateral bending, axial rotation, and then performed t-tests to determine statistical differences. These results show the total range of motion. So as you can see, there was no significant differences between healthier individuals with mechanical neck pain for either lateral bending or axial rotation. But when we look at the coupling ratio, specifically for lateral bending here, we did note that we did have ipsilateral axial rotation coupled with the primary axis of lateral bending. We did see a non-significant decrease in the amount of coupling with individuals with mechanical neck pain. We are continuing to to recruit and analyze data. So we hope that, maybe we'll see some differences as we get that larger sample size. We did note a significant decrease in the amount of extension that occurred during this activity with individuals with mechanical neck pain. And when we dove into that a little bit more, what we noticed is that the individuals in the mechanical neck pain group seem to be in a more flexed posture throughout the motion by comparison. When you look at the coupling ratio for axial rotation, we also noted that axial rotation was coupled with ipsilateral lateral bending, but we did not see any differences between the groups for bending. However, for extension, we did notice a trend in where, again, these individuals with mechanical neck pain tended to be in a more flexed position. So in summary, coupling direction was consistent with previous literature, and those individuals with mechanical neck pain demonstrated a reduced coupling ratio, and that was specifically found in we saw less coupling into extension during lateral bending and axial rotation. We're continuing to grow our sample size and build upon these results and explore these data further. So I'd like to thank the other people in my lab as well as the funding sources. Thanks for your time.
Thank you, Aaron. And our next talk is from the same group. Matthew McEwen will be presenting, and the title is Cervical Spine Neuroforaminal Changes During a Multi-Axial Movement, Comparison of a Cohort with Chronic Neck Pain and Healthy Controls.
Hello, thank you for the interruption. Is everything looking okay? Can you guys hear me?
Yes, great.
Fantastic. So today I'm going to be discussing our abstract titled Cervical Neuroforaminal Changes During a Multi-Axial Movement. And as Dr. Ellingson alluded, I'm presenting on behalf of Craig Cage, the primary author of this work, who unfortunately could not be here today. So understanding more about neck pain is the drive motivation for this study. It currently impacts a substantial percentage of the population annually. The chronic nature of the pain causes it to rank 4th overall in years lived with disability. Current assessment of neuroforaminal spacing is limited to static, planar, and/or superficial evaluation. The radiograph here shows C3, C4 foraminal stenosis from osteophyte and facet joint hypertrophy. During coupled motion, the spacing will dynamically decrease in size. Currently, we do not have a good way to assess this. We have the Sperling's test that is designed to close the neuroforamen through serially moving into lateral bending, extension, axial rotation, and applying axial compression. We invested a circumduction task that is a multi-axial task that investigates the unique coupling of the cervical spine and mimics positions similar to the Sperling's test during dynamic physiological loading motion. The purpose of this study was twofold. First, we wanted to compare the neuroforaminal height changes between those with chronic mechanical neck pain and a healthy cohort. And second, we wanted to compare the in vivo kinematics during a multi-axial circumduction task. The neuroforaminal height was the distance between the most superior point of the inferior pedicle on C5 and the most inferior point of the superior pedicle on C6. Likewise, the neuroforaminal width was the distance between the anterolateral inferior notch and the posterolateral superior notch. We then compared the neuroforaminal height and width changes between those with chronic mechanical neck pain and the healthy cohort during a multi-axial circumduction task. The top table compares the rotational range of motion for the right circumduction task for the C5, C6 level between controls and those with mechanical neck pain. There was a significant difference observed in those with mechanical neck pain as they had a greater flexion extension range of motion. To calculate the percent change in neuroforaminal height and width, we compared these dynamic values to those measured in a neutral position in the CT, and there was no significant differences. So this figure has since been updated since the abstract to adjust for some computational corrections, but here we can see the dynamic changes of the neuroforaminal height associated with the right circumduction task. The figure at the top showcases the motion. It starts with flexion, then into lateral bending and axial rotation towards extension, and then axial rotation and lateral bending again back to flexion. Controls are the solid line, and those with mechanical neck pain are the dashed line for the figure. We've highlighted the area below a 20% decrease in neuroforaminal height based on previous neuroforaminal spacing work. We can see here that only one of the controls enters this highlighted area, with a difference in time spent less than 20% decrease shown in the table to the right. As you can see, the averages are quite different, and this is demonstrated by a trend with a p-value of 0.07. A more conservative Welch's t-test was used due to the unequal variances between groups. And we also compared the amount of time spent in extension for each motion trial, as that has been associated with reduced neuroforaminal spacing. Similarly to the previous figure, we're now looking at the percent change in neuroforaminal width from neutral. We see that no controls entered the highlighted range, but all 3 of the mechanical neck pain did. Similarly, a more conservative Welch t-test was used due to the unequal variance between groups. Again, the difference spent in less than 20% decrease was shown in the table to the right. And as you can see, the averages are quite different, and this demonstrated a statistical trend. Even with a limited sample size, we were able to detect difference, namely those with mechanical neck pain demonstrates greater flexion extension range of motion at C5, C6, as well as a trend to spend more time in a reduced neuroforaminal height and neuroforaminal width, which may have an implication on symptoms. Some limitations that we had were a small sample size, not using time normalized data, and not using a group with cervical radiculopathy. I would like to acknowledge other members of the lab, similarly to Dr. Ellingson, and thank everyone for their funding sources and for their time.
Thank you, Matthew. Great talk. And our final talk of this session is by Saman Madani. And the talk is Dynamic Stability of the Spine when Assisted with Back Support Exoskeletons.
All right. Can you see my screen and can you hear me?
Yes, perfect.
Awesome, thank you. Yeah, thank you very much for the introduction. I'd like to present my work on dynamic stability of the spine when assisted with back support exoskeletons, and I'd like to thank my co-authors for their contributions in this study. So low back pain remains a common health problem in the workplace, and management of its risk factors is still a big challenge among practitioners and ergonomists. Manual material handling tasks have been repeatedly reported as a risk factor for low back pain, and in many work scenarios, these tasks are difficult to design out because of the flexibility and adaptability of human workers required in those work scenarios. And recently, back support exoskeletons have been introduced as an alternative and promising intervention to reduce the risk of low back pain by providing extra support to lower back and hip muscles. Although a growing body of literature is pointing towards the efficacy of BSCs in reducing low back demand, limited evidence is available regarding the unintended effects of back support exoskeletons or BSEs on trunk neuromuscular control, which is also commonly reported as a risk factor for low back pain. And also the evidence is lacking regarding the differences between BSC designs and across diverse working conditions. So to address these research gaps, we completed a study to assess the dynamic stability of the spine when using 2 passive back support exoskeletons during symmetric and asymmetric repetitive lifting. Specifically, we compared 2 different devices with distinct design characteristics. These devices were BackX Model AC and Levo version 2.5. And so the participants performed symmetric and asymmetric repetitive liftings for this study. Symmetric tasks were performed from ground and knee height level, and asymmetric tasks was only performed from knee height level because of the limitations of reaching to ground level in asymmetric lifting. And each participant completed freestyle lifting for 4 minutes, and their pace was controlled at 10 cycles per minute, and their body weight was also controlled at 10% of their body mass. I'm sorry, the box weight was controlled at 10% of their body mass. So a group of 9 males and 9 females were recruited for the study with no recent or current musculoskeletal disorders or injuries, and each participant completed a training session of about 1 hour just to get familiar with the exoskeletons and pick their preferred support level. They also performed an experimental session on a separate day, which lasted about 4 hours to complete all the trials. We completed a large set of data, but for the purpose of this study, we used the inertial motion capture units data from trunk and pelvis segments. And for our independent variables, we looked at intervention, gender and task condition, and our dependent variables included short-term and long-term maximum Lyapunov exponent, as well as maximum flow K multipliers for both trunk and pelvis segments at 4 Poincare sections of lifting cycle. Our results showed that using LEVO significantly increased maximum Lyapunov exponent for pelvis segment by up to around 8%. Also, LEVO use significantly increased maximum flow K multipliers at all cross sections, at all Poincare sections for both trunk and pelvis by up to around 10%, as you can see in this figure. So just some of the limitations. We looked at short-term effects of BSEs here, specifically 4 minutes of repetitive lifting and 1 hour of training session. And mainly younger participants were recruited from college students. And this study was performed in a controlled lab environment, so we didn't look at suboptimal working conditions, like uneven working surfaces or restricted working spaces. Just the key points and takeaways from this study. So the short-term use of a passive back supported exoskeleton can adversely influence the neuromuscular control of the spine. And even for a given device, these effects may be task dependent. For example, we saw less stable trunk movements with moderate lifting conditions as compared to extreme lifting conditions. And finally, future work is needed to generalize these effects in terms of to generalize the different BSE design approaches in terms of their effects on neuromuscular control. And more details of our study results are presented in our recently published paper in Journal of Biomechanics. And you can always also reach me out at medine@vt.edu if you have any questions. Thank you very much.
Sorry, I was muted. Excellent. Another 3 great talks. Thank you, all of you. And we can feel free to have any questions now. Looks like there's one in the chat.
I was also actually, before we maybe get to that one, I had another one as well here that I had bookmarked for Christina from the last group. So I thought maybe before we move on to the cervical spine, I would tag that one in. Quick question for you, Christina. I know it seemed like in your study, you didn't necessarily see a difference in performance across your users with the prosthesis and those without. And I was curious if maybe a factor in that was someone's experience or expertise with their prosthesis, and if that was a factor in your study. And then I was also thinking about perhaps it seemed that there was maybe some greater effort or greater corrections that you saw in the prosthesis users, and if that was maybe a factor attributed to the type of prosthesis they were using or other factors that maybe are relevant to your work. So a bit of an open-ended, but curious to hear your thoughts.
Thank you for that question. We did collect people's experience level, a year since amputation, how often they use their prosthesis. I have personally not looked at the correlation between those and my outcomes, but I certainly can. We've used different data set, but completed by same individuals in our other previous studies before, and we didn't necessarily really see a correlation between users' experience level and some of the quantitative measures that we were looking at within those individuals as well. And my next step actually is to look at whether prosthesis type actually does impact the outcomes that we were looking at. I just haven't gotten to it. There are 2 most commonly used types of active prosthesis are body powered versus myoelectric. Body powered user, you saw on our slide, it's the one with the hook and the terminal device connected with a cable that you pull using your scapula. Myoelectric prosthesis is actually what Michael's presentation was about, controlled using EMG signals. So they're very different mechanisms of actuation. So it's a hypothesis that prosthesis type will likely impact some of these outcomes as well. Thank you.
Yeah, it'll be great to continue to follow and learn more. And Anita, you mentioned there was another question.
Yes, I think it came directly to me. I didn't
Okay.
realize that. So this is for our last talk on exoskeletons. And the question is from Jacob Banks. The question is, what about adaptation effects? Did you look at how stability was impacted without an exo after using the exoskeleton?
Yeah, that is a great question. So we actually reported our results regarding the kinematics data in another study. I can refer you to that study as well. So in that study, we looked at kinematic changes during these 4 minutes of lifting, and we didn't see significant differences, like from the beginning to the end. So, and the results of exoskeletons also didn't have much impact on the behavior or adaptability of the participants. But certainly, like we didn't look at the adaptability after use of exoskeletons. That is a great question to answer in later research. But thank you, that was a great question.
As a little follow-up, maybe someone, could you maybe comment on the differences between the two exoskeletons that you used? Was one more stiff, or the way they were attached to the body, or anything like that?
Oh, sure, definitely. I'm not sure if I still can share my screen, but just maybe. Let's see. So these two exoskeletons, so the reason we selected these two were because, first of all, these were the only two available exoskeletons in the commercial market at the time. So these were, and also they have different support mechanisms. So basically they provide a supportive torque around hip joint, but back X basically pulls torso to the back by providing support, but here levo basically pushes against chest. So these are, like, we think that they have kind of different mechanisms in terms of providing support to the trunk. So this is basically pulling backwards from here. You can see there is a structure, there's a spinal structure here on the back, and it is basically pulling the shoulder backwards and from here. But with levo, all the torque and all the pressure is applied to the chest, and it is basically pushing against chest to provide extra support. So that is the main reason, but also they have different design characteristics, like how to fast. I mean, this one has more padding. We call it like maybe more, and it's like a little bit heavier back X, but levo is like less profile. I mean, low profile, and it has less paddings, and it is a little bit lighter than back X.
Thank you for that explanation.
Sure.
It would be interesting to also know if there were differences in the way people liked the usability, I guess.
Yeah, we actually reported those in a separate paper as well. Yeah, there was actually among these 18 participants, there was a slight preference towards back X, but we couldn't detect much difference. Like maybe 10 participants selected back X in terms of their usability, and 8 participants went for levo. But overall, it was like half and half, so we couldn't say the difference maybe with this sample size. But excellent questions. Thank you.
Any other questions for any of these excellent talks? I guess I have a couple of more questions for the cervical spine group. Aaron, I know this is a hard question, but do you think that the differences you found, those coupling ratios, would be a cause or an effect of neck pain?
Yeah, I mean,
That's
obviously
not
a
fair.
really good question. It's hard to comment on, maybe some of the differences that we might be seeing with ipsilateral rotation. But I think that they're kind of tied together. I think that you tend to see people with neck pain in kind of a more hunched over, flexed posture in general. Chicken or the egg, I mean, I don't know. I mean, I think that we're starting to see a little bit more of the younger generation come up with neck pain and kind of being in that, forward posture, looking at your phone or some sort of device in front of you. That potentially that's, coming into describing some of the causes. But obviously in a cross-sectional study such as that we're doing, it's very difficult to be able to tease that out.
Sure, I know.
Yeah.
And then Matthew, I think I had another question for you. So is there a recommendation now among physical therapists to not do the extension part of if you're doing maybe a little neck warm up or something, to just kind of do the lateral bending and flexion?
That's a fantastic question. I'm not a trained physical therapist like Craig, so he'd probably have a better answer for this, but I believe it still should be a part of the stretch because it will affect other muscles. I just think that when you're experiencing neck pain, it should likely be avoided because that could be a root cause. Be sort of the best way I could answer that question.
Mm-hmm. And I guess, I guess you probably did, if you could get this out of your data, but is a pure flexion extension just as bad as the circumduction in terms of decreasing the neuroforaminal height and width?
That's a great question. I don't have all the data in front of me to see that. Aaron might be able to chime in a little bit better to answer that question particularly.
Yeah, depending on if you're looking at height or width, the area or the time point of when maximum closure happens is slightly different, but it tends to happen, at least for the circumduction activity, tends to happen before you get to maximum extension, kind of when you're in so we have the individuals go into lateral bending and then try to have them go into rotation up over their shoulder. Tends to happen right after maximum axial rotation. When they start to go into extension is where we start to see the maximum height closure. I'd have to look at the data again to see when rotation, but I think that happens slightly before that for the minimum width.
Mm-hmm.
And we do have all the data. So the data that I presented and the data that Matt presented are all in the same individuals. So we do have biplane video radiography data for the planar trials as well.
Oh, great.
So we're trying to get through all of that data right now.
A lot of data, I'm sure.
And maybe just a last, oh, sorry.
No, I was just going to say, as I was trying to recruit postdocs from both of your labs recently. So.
I was just going to say, as a last kind of like follow-up question to that too, if you in that kind of combined motion where you were saying the time point of where you see maximum closure can occur differently depending on how you look at it. I don't remember if I maybe missed it in your slides, but do you look at symptoms and if people have symptoms during that, and does that relate at all to timing of symptoms to timing of max closure?
Yeah, that's a great question. And we tried to experiment a little bit with having them bring in a little bit of a buzzer or something like that to be able to do that when it happens.
Yeah.
But the complexity of the task, I think, was too much for them to be able to do it and synchronously do that. So after each trial, we asked if they experienced any change in symptoms, any nerve impingement, any tingling, anything like that. And then we kind of have a radial diagram that we try to make them make some tick marks on and be able to associate that back. But haven't gotten to the point of digging through that data yet.
Yeah, a bit of a multitasking with trying to do that and time your symptoms, but that's really interesting. I'd be curious to see how the radial plots turn out too. It looks like we may have one more in the chat. I know we're just at the very end. So a question from Nicole Ramo. For Aaron and Matt, is there an advantage of measuring 2D area versus 1D height and width? If you have a quick answer, feel free to chime in, or also spatial chat as a reminder.
Sure. Quickly, I would say, I think both of them are a limitation and we should be looking at more of a volumetric measurement. But there has been some preliminary data that suggests that perhaps width is a little bit more sensitive to symptomology.
Thank you. And I will just, we can follow up in, if anybody would like to join us in the spatial chat, and it's room S3 Aristotle. I just found that. So it would be great to continue any of these conversations, or just have some fun talk in the spatial chat. All right, and just again, another round of applause for all 11 presenters. You did a great job, and yeah, great topics.
Thank you, Anita, for helping to bring us together and make it happen.
I'm sorry about my departure.
It worked out.
Yeah, that was
I
fine.
I knew that you could handle it. So, all right. Thanks, Sam.
Yeah, no problem.
teaching
Thanks,
us.
everybody. That went super smooth. That you guys made it really easy on me. So that was that was awesome.
Great. We didn't have to kick anyone out for poor behavior either. So that was good.
Oh yeah. Doesn't happen very often, but it does happen every once in a while.
Great.
Yeah. No, awesome. Thank you guys so much.
Thank
I
you.
will end the session.
Okay, great.
So yeah, thank you all. I believe if you have one of you must have Julia's contact. If there's anything else that you need, you can always contact her, and she can ping me, and I can get in touch with you guys that way. But yeah, thanks again for everything.
Great. Yeah.
Have a good rest of the conference.
Thanks.
Hi, Emma. Bye, Anita. Thank you, guys.
Take care, y'all.